And these are two of them, one Dr. Vanderpie from Ghana and Dr. from Turkey. And please, if you have any mentors that you think are really fabulous, send in your nominations next year. We just closed it for this year, but we really want to have more recognition of our international mentors and would love to have one from Egypt. So think about that when you're in next year when the fall comes. So thank you so much.
Thank you, Professor Sandra Swain. I would like to introduce my professor, Dr. Mohammed Farouk, who is a professor of oncology at Alexandria University. To the podium, he will be leading our discussion for the session. Please proceed, sir.
Bismillah ar-Rahman ar-Rahim. Thanks, my great presenter, for the excellent talks. I think we have Professor Cortez and we have Professor Conti with us. Yes. We are looking for any questions from the floor, actually. We have Professor Conti with us talking about the low HER2 breast cancer, and Professor Javier Cortez talking about the neoadjuvant and adjuvant setting for early breast cancer. Do we have anything from the panelists?
We can ask Professor Cortez, please.
Yes, Professor Azad, تفضل.
In the Catherine trial, TDM1 definitely benefited all the patients with residual disease, whatever the biomarkers used.
الفويس دكتور عزة لو سمحت.
Can you please?
Okay, sorry. In the Catherine trial, TDM1 benefited all the patients with residual disease, whatever the biomarkers used. But do you think that patients who present in the pre-treatment biopsy with focal HER2 overexpression or HER2 heterogeneous disease, if they have residual disease after surgery, do you think that TDM1 can rescue this specific group of patients with focal HER2 positivity?
I need technical
Cortez.
support. Do we have Professor Javier Cortez with us or not?
He's muted.
Again?
No, I think it's Professor Conti who is with us.
Okay.
Okay, so.
Yes, I'm here.
Oh, okay.
Hello.
So did you hear the question, sir?
No, could you please repeat your question, because the sound is not very good.
Okay.
Yeah, please, Dr. Azza, can you raise your voice, please?
My question is in the Catherine trial, okay? Definitely TDM1 benefited all the patients with residual disease. But my question is, for patients who present in the pre-treatment biopsy with a focal HER2 positivity, HER2 heterogeneity, and turn to have a residual disease after surgery, do you think that TDM1 can rescue this specific group of patients with just focal HER2?
There were patients in the Catherine trial who had...
Thank you for the opportunity to talk about
HER2 negative disease in the residual tumor at time of surgery, and this was a small number of patients, but these patients equally benefited from TDM1. So in my opinion, for the moment, all the patients who had a positive HER2 definition should receive TDM1 after neoadjuvant chemo plus HER2 therapy.
Thanks.
Professor Conti, you mentioned the HER2 heterogeneity.
Yes.
Yes. I wonder what about the percentage of this heterogeneity in HER2 breast cancer, and whether we should oblige or ask the pathologists to demonstrate whether there is heterogeneity or not, because maybe it will benefit us in the neoadjuvant setting. It may, if there is no heterogeneity, we could go for anti-HER2 alone without chemotherapy. If there is heterogeneity, we will need chemotherapy. What's your input about that?
Yeah, I think this is a very important point. You raised a very important point, and this is one of the reasons why, in my view, for the moment, still the best regimen is a combination of chemotherapy plus anti-HER2 therapy, because at the end, the majority of the tumors are heterogeneous. There are, of course, tumors with a high prevalence of HER2 positive cells, but there are on the other side tumor with a low prevalence of HER2 positive cells. So in this case, a pure anti-HER2 therapy might be suboptimal. Of course, the situation might be different, might be, because we are not yet sure, might be different with a new antibody drug conjugates, because in this case, with the new very potent anti-HER2 antibody drug conjugates, it is quite possible that the so-called bystander effect might overcome the problem of HER2 heterogeneity. But at present, up to now, in my view, the best approach is a combination of chemotherapy plus anti-HER2 treatment precisely because of the issue of heterogeneity.
Thank you. One more question actually about is there a standard of care now for third-line therapy for metastatic HER2, who those failed the trastuzumab and TDM1? Could we say that this drug is the standard of care, or it is according to the situation if the patient is having brain mets, or what's your input, please, about that?
So your question is if trastuzumab deruxtecan can be considered the standard of care?
Yeah.
We have two very important new drugs. One is trastuzumab deruxtecan, the other is the triple combination of capecitabine, trastuzumab, and tucatinib. Also, this combination seems to be quite active in heavily pretreated HER2 metastatic breast cancer patients. So by sure, unfortunately, these two drugs combinations are not yet available in Europe, will be soon available, and by sure the data from clinical trial are quite promising. Apart from these two new options, we do have, I think, even now, some available options. Lapatinib, capecitabine is still available option. Trastuzumab in conjunction with other cytotoxic is still an option. So many patients with HER2-driven metastatic disease can benefit from multiple lines of anti-HER2 based treatments.
Thank you, sir. And as we are out of time now, I have to thank you all, the presenters, the panelists, and the audience, and the session is over. Thank you.
Thank you, Professor.